Good afternoon, Ajahn. It's my great honor today to present my thesis proposal with the title Effects of High-Intensity Inspiratory Muscle Training in Patients with Heart Failure with Mildly Reduced and Preserved Ejection Fraction, a randomized controlled trial. The outline that I would like to cover today includes introduction and literature review, gaps of knowledge, research questions, research methodology, and statistical analysis. I'll start up with the introduction and literature review. Heart failure is a common condition which is a big problem worldwide. The prevalence of heart failure in general population is 1 to 3%. It means that over 240 million people were living with heart failure in 2022. If you look at the mortality, you could see that over half of heart failure patients die within 5 years. And the annual healthcare cost for heart failure is up to 25,000 euro or over 900,000 Thai baht. Let's take a look in Thailand. Heart failure prevalence was estimated to be 0.4%. In Thailand, the heart failure hospitalization still increases, and the annual heart failure cost per patient was 120,000 Thai baht. The hospitalized heart failure care costs were over 250,000 Thai baht. As you may know that heart failure is a big problem. So let's move on the classification of heart failure. Heart failure could be classified into 3 types. Heart failure with preserved ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction is defined as the presence of the symptoms and signs of heart failure, plus left ventricular ejection fraction equal or greater than 50%, plus evidence of cardiac structural and or functional abnormalities at rest or with exercise. The definition of heart failure with mildly reduced ejection fraction is similar to heart failure with preserved ejection fraction, except the left ventricular ejection fraction is in between 40 and 50%. So let's take a closer look at heart failure with preserved ejection fraction and mildly reduced ejection fraction. In this figure, on the left-hand graph, the vertical axis shows the proportion of the patients with heart failure with preserved ejection fraction. You can see that the trend of the prevalence of heart failure with preserved ejection fraction increased over time. On the right graph, the y-axis captures the number of admissions. You could see that the red line shows the number of heart failure with preserved ejection fraction continue to increase, while the black line, the number of heart failure with reduced ejection fraction seems to be the same. In this cohort, you can see that more than half of patients with heart failure were mildly reduced and preserved ejection fraction. And the 5-year mortality rate of those patients were not different from the heart failure patients with reduced ejection fraction. And again, 5-year mortality rate in this cohort was around 75%, and the mortality rate in readmission was up to 97%. One of the most common problems of heart failure with preserved ejection fraction and mildly reduced ejection fraction is exercise intolerance. So let's go further on it. Firstly, what is exercise intolerance? It is defined as a complex clinical syndrome represented with reduced oxygen consumption or VO2 during physiological stimulation. Oxygen consumption will be affected by cardiovascular, pulmonary, and muscle structure and function. There are some ways to diagnose exercise intolerance. Firstly, the 6-minute walk test. It is a simple and commonly used objective assessment method in clinical practice. The patients will be instructed to cover the maximal distance, possibly in 6 minutes, at a self-graded walking speed and pausing to rest when needed. The 6-minute walk test provides information about the distance, patient's exertion, the adaptation of their cardiopulmonary system during and after the test, and the patients with 6-minute walking distance less than 300 meters will have a high risk of mortality. Secondly, the cardiopulmonary exercise test or CPET. It is a comprehensive test, combines exercise with measurements of various physiological parameters such as heart rate, blood pressure, oxygen consumption, carbon dioxide production, respiratory rate, ventilation, and electrical activities of the heart. During the exercise test, the work rate will be incremental, and the peak oxygen consumption is determined as the highest oxygen consumption achieved when patients reach maximum effort during the test. And peak oxygen consumption is considered normal when it is equal or greater than 85% of predicted value, or greater than 20 millimeter per kilogram per minute, and abnormal when it is less than 85% of predicted value. The evidence of exercise intolerance in the patients with heart failure with preserved ejection fraction is shown in this figure. You could see that the average of peak oxygen consumption is in this group of patients is around 15 millimeter per kilogram per minute, which is less than 20 and below the normal range. In addition, many activities of daily living, such as dressing, making bed, or walking, which is very easy for healthy adults, require a near maximum effort at a lactate threshold for patients with heart failure with preserved ejection fraction. Let's take a look deeper in the pathophysiological abnormalities contributes to the clinical manifestation in heart failure with preserved ejection fraction. The risk factors such as comorbidities, aging, obesity, physical inactivity, and systemic inflammation lead to downstream of multi-organ dysfunction, frailty, and cardiac dysfunction, and skeletal muscle myopathy, which is resulting in skeletal muscle weakness and exercise intolerance. The skeletal muscle weakness is explained by some mechanisms such as respiratory muscle atrophy, change in muscle fiber types, muscle metabolic reflex, reduced oxidative capacity, ventilation inefficiency, and physical deconditioning. So from the previous section, you could see that skeletal muscle weakness is a key contributor of exercise intolerance. Let's further explore the status of skeletal muscle weakness in heart failure with preserved ejection fraction. The prevalence of skeletal muscle weakness in heart failure with preserved ejection fraction is 30 to 40%. And skeletal muscle weakness is defined as maximal inspirator pressure or MIP less than 70% of predicted value. Maximal inspirator pressure or MIP is a measurement used to assess the strength and function of the inspiratory muscle, particularly the diaphragm. To assess MIP, patients will be instructed to inhale forcefully at residual volume to against an occluded airway of a digital device like this picture. The graph shows the pattern of a maximal inspiratory pressure result. The patients will need to keep the plateau in 2 seconds before exhalation. In clinical practice, inspiratory muscle weakness is considered as a poor prognostic factor in heart failure. This figure represented the survival rate of heart failure patients with inspiratory muscle weakness in red line, and those without inspiratory muscle weakness by the blue line. You could see that the patients with inspiratory muscle weakness had a significant lower survival rate than those without inspiratory muscle weakness in both heart failure with reduced and preserved ejection fraction. So, what is the solution for inspiratory muscle weakness? An effective way to strengthen inspiratory muscle in patients with heart failure with preserved ejection fraction is respiratory muscle training. In this method, inspiratory muscle training with resistance training is of great concern because inspiration is generally an active progress of diaphragm activities, and it plays a vital role in oxygen uptake efficacy. In addition, the resistance training is user-friendly and more cost-effective than other devices. While the patient trains the inspiratory muscle, the inspiratory muscle training device will provide a stable resistance while inhalation, and the patient needs to inhale strong enough to get over the threshold. So, how inspiratory muscle training could improve functional capacity? Inspiratory muscle training directly strengthens the respiratory muscle, including diaphragm and intercostal muscles. By that way, inspiratory muscle training improves the pulmonary function, which is one of the most important factors to increase peak oxygen consumption, as I told you, and it means that functional capacity is improved. In order to gain expected outcome, the inspiratory muscle training program will be set based on 3 components: the intensity, the frequency, and duration. The intensity depends on the percentage of maximal inspiratory pressure and divided to high intensity, moderate intensity, and low intensity. An appropriate intensity is very important to optimize the outcomes. For example, patients with heart failure with preserved ejection fraction have higher functional capacity compared to heart failure with reduced ejection fraction. So they need to train at higher intensity. There are some previous studies of inspiratory muscle training in patients with heart failure with preserved ejection fraction. Until now, there are only 2 trials were performed to evaluate the efficacy of IMT in patients with heart failure with mildly reduced with preserved ejection fraction. But both of them use low to moderate intensity IMT. In addition, they use unblinded trial design, small sample size, and lack of report of the compliance to home-based IMT program. And an interesting finding is no previous studies evaluate effects of inspiratory muscle training in patients with heart failure with mildly reduced ejection fraction. So the gap of knowledge is that there have been no study conducted to evaluate the effects and safety of high-intensity inspiratory muscle training on patients with heart failure with mildly reduced and preserved ejection fraction. Based on the current evidence, we propose 2 novel research questions. Firstly, does the home-based high-intensity inspiratory muscle training program increase peak oxygen consumption? from baseline more than that in sham controls in patients with heart failure with mildly reduced and preserved ejection fraction. And the second question is that, is the home-based high-intensity inspirator muscle training program safe, and does it improve maximal inspiratory pressure, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters? So we conduct this study with two objectives. The primary objective is to evaluate the effects of the home-based high-intensity IMT program on an increase in peak oxygen consumption from baseline in patients with heart failure with mildly reduced and preserved ejection fraction compared to sham controls. And the secondary objectives are to evaluate the safety and the effects of the home-based high-intensity inspirator muscle training program on improvements of maximal inspiratory pressure, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters. And we hypothesized that the home-based high-intensity IMT program increased peak oxygen consumption from baseline more than that in sham controls in patients with heart failure with mildly reduced and preserved ejection fraction. In addition, the program is safe and it improves maximal inspiratory pressure, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters from baseline more than those in sham controls in patients with heart failure with mildly reduced and preserved ejection fraction. This is my conceptual framework. The patients with mildly reduced and preserved ejection fraction will present with inspirator muscle weakness, which is also affected by other factors such as aging, nutritional deficiencies, obesity, medications, and comorbidities. And inspirator muscle training helps to increase the strength, speed of shortening, power output, and endurance of inspirator muscle. By that way, inspirator muscle training could improve peak oxygen consumption and other outcomes. There are also some confounders that could affect the oxygen consumption, such as beta blocker, gender, and inadequate exercise. I have just explained the reason why I look forward to conducting this research. Now I will proceed with clarifying the method for undertaking it. Firstly, the study design. We use randomized controlled trial design. The patients with heart failure with mildly reduced and preserved ejection fraction will be assessed for eligibility, and they will be excluded if they meet exclusion criteria. Then they will be randomized to two groups, high-intensity IMT and sham IMT, and the follow-up time will be 8 weeks. The eligible criteria. I will include the patients with diagnosis of heart failure with mildly reduced and preserved ejection fraction with age 18 or older and NYHA class 2 and 3. And the patients need to be stable with dose of heart failure medications for at least 4 weeks. And the exclusion criteria are gait problem, worsening heart failure, recent angina or open heart surgery, end-stage renal disease, post-heart transplantation, anemia, moderate to severe valvular disease, significant primary pulmonary disease, and comorbidities with life expectancy less than 1 year, and some withdrawal criteria as are presented in this slide. To ensure the randomness and blindness, we use block randomization method with a block of 4 and 6 in a 1:1 ratio into 2 groups. And the cardiologist, outcome measurement, and me as a data analysis researcher are blinded to the patient's allocation group, and all participants are blinded to other intervention. The intervention protocol. The high-intensity IMT will be performed with warm-up in 5 minutes, and the training resistance will be set at 30% of MIP in the first week, 50% of MIP in the second week, and 70% MIP from the third week. And the cooldown will be performed in 5 minutes. The SHAM IMT warm-up and cooldown will be performed similar to high-intensity IMT program, and the training resistance will be kept at 15% of MIP during the period of intervention. This is the device will be used in this study. It includes 11 adjustable levels of resistance corresponding to the resistance from 17 to 89 to 98 centimeter water. The study endpoints. Our primary endpoint is the change in peak oxygen consumption at 8 weeks, and the secondary endpoints are maximal inspiratory pressure, 6-minute walking distance, quality of life, echocardiographic diastolic parameters, and experience of some adverse events. I propose some ways to manage patients' compliance, include a logbook, phone calls every week, and a checklist. The figures show the data collection timelines from the admission to the end of the intervention. All this data will be collected during the first meeting when patients are eligible for the study. Additionally, they will be taught the training program prior to the study. And to ensure that the intensity is maintained at the target level, patients will undergo reassessment of maximal inspiratory pressure at the beginning of the second, third, and fifth week in order to adjust the training resistance. All the outcomes will be collected again at the end of the study. For the sample size calculation, we set the power of the study at 80%, and the alpha level is 0.05. The result shows that we need 12 participants per group and 24 patients for 2 groups. We assume that 15% of patients will drop out of the study, so the total participants is 29. The statistical analysis. Intention to treat analysis will be considered. The normality of data is examined by Shapiro-Wilk test, and the statistical significance level is p-value less than 0.05. The table shows the outcomes and statistical tests are used for each. Independent t-test and chi-square test will be used depends on the types of data. The limitations. Some problems with compliance could arise, but we use phone call every week and diary to alleviate the limitations. I intend to apply for the 90th anniversary of Chulalongkorn University scholarship to serve my study. The ethical issues. Firstly, cardiac rehabilitation is not implemented as a mandatory routine in the King Chulalongkorn Memorial Hospital. So comparing a high-intensity inspiratory muscle training program with sham control allows for a fair comparison to the usual care, while ensuring a non-biased and blinded study design. We also provide consent forms and opportunities to ask any question, and participants can withdraw from the research at any time. This is my study timeline, and I'm in the first stage. Thank you very much for your attention. I look forward to receiving your suggestions to help improve my thesis. Thank you very much, my friends.